You are welcome to my channel. Thanks for listening. Remembering to share my presentations and subscribing if you haven't. But if you have subscribed to my channel before and you are visiting again, I'm saying a big thank you. Today, I'll not waste your time. Let's go straight to the point. Platelets transfusion. What is this all about? In a bit, you'll understand. Let's pause there a little bit. I have published a separate presentation on blood product transfusion tagged A to Z, and here is the link. If you click on this link, it will take you to all blood products, red blood cells, platelets, plasma, fresh frozen plasma, cryoprecipitate, albumin, immunoglobulins, name it, all here. Okay? But because not everyone will be able to sit down for 2 hours, 55 minutes, I've decided to bring the platelets alone out and then talk about platelets right now. So if your focus is getting piece of info on platelets, then you're fine. But if you want to know more about the rest, then you can click on this very link. Before embarking on transfusion of any of the blood products at all, we must take care of the legal aspect of blood transfusion of any of the products. So now it's about platelets. So I'm going to sit down with the patient or the substitute decision maker if the patient is no longer capable of doing that, or because there's an appointment by the court and whatever the case may be, or the parents in the case of pediatric age group where parents will have to take decision on their behalf. With that, there must be a signed consent, and the signed consent will only take place after thorough explanation as per the reason or reasons for the transfusion of the specific product, in this case, the platelets. So I would let the patient know that I'm going to give the particular or specific product like platelets, and why that must be explained. Alternatives must be stated. If we have one or more, I must state that. And if we don't have any other alternative, then that must be clearly defined to the patient. Then I will go over the possible side effects and report all transfusion reaction or reactions promptly to the parents in the case of the pediatric age group, to substitute decision maker if the patient is incapable of taking decision by him or herself, or to the recipient of the product, the patient who is capable of taking decision. In certain situations, you may be forced to seek court order. It depends on what is obtainable in your jurisdiction. For example, if you could make that determination that the parent is not acting in the best interest of the child or children, then you may seek court order, depending on what is obtainable in your jurisdiction. Let your head authority be informed. Or you notice that the substitute decision maker is not acting in the best interest of the patient that has become incapable, then you may seek court order. But like I said also, it depends on what is obtainable in your jurisdiction. However, court order is unnecessary if the patient is capable and old enough to make that decision and he or she has refused after you've explained that there will be no alternative, this is the reason why you want to use the product, and he or she has chosen or vehemently repeating it that I don't want it, then that is the end. No need of court order. Why do we need the legal aspect here? Well, to those who are not familiar with Jehovah's Witness and Jehovah's Witness doctrine, I don't want you to get into trouble before you learn your lesson. If a Jehovah's Witness says, I don't want the product, please take it like that. I will not waste your time here because I'm bringing out this presentation to reduce the length of the presentation on the other long one of 2 hours 55 minutes. So let me skip that. If you want to know more, go back and click on the link to the full presentation on blood products, transfusion. In law and in the medical legal aspects of medical practice, any treatment that ends up in dispute without consent before then is battery. Note the following, please. Please kindly find out the level of the iron before you embark on transfusion. Ferritin, total binding capacity, iron level. You just do all those investigations. Why that? Iron deficiency can worsen platelet dysfunction. We must stop all antiplatelet agents before embarking on platelet transfusion. We should give tranexamic acid at about 15 milligrams per kilogram intravenously. We can give up to 2 grams if there is severe bleeding, or there is tendency to have severe bleeding. Now, how do we obtain the platelet that we intend to transfuse? That could be through pooled platelets or by apheresis. The pooled platelets will give us more volume of platelets because we are going to get that from bovine code from 4 different donors into the plasma of one of the donors. Imagine that. But in the case of apheresis, we'll get less volume because we will get apheresis just from one donor. So less volume compared to pooled platelets. We can use citrate phosphate dextrose as the anticoagulant to keep the platelets, okay? And it could also be suspended in platelet additive solution after being washed to remove the plasma. It must be agitated. Why that? We cannot get platelets and keep it static in one spot. There's going to be platelet aggregation, right? And we don't want that. The people working, taking care of platelets and other products in all the blood banks, they're familiar with this. When it comes to platelets, it's going to be at room temperature and will be agitated constantly. If not, there'll be platelet aggregation. Now, washed platelets. By way of definition, washed platelets simply means you've washed these platelets. And what have you gotten rid of? You've gotten rid of proteins, antibodies, cytokines, metabolites, and so on. And here, you may use bovine coat or use apheresis, okay? And then you wash. You may decide to use normal saline or citrate. Why do we need that? Ideally, IgA deficient donors should be the ones that will donate the platelets to any recipient that is IgA deficient or in the normal situation, right? But when we have IgA deficient patient with antibodies to IgA, and we cannot get IgA deficient donors, then we must make use of the platelets that is available, right? Then we embark on washing. So we use washed platelets in that situation. Also, when there's anaphylactic reactions to platelet transfusion, and we've looked for the cause of that and we are not sure, we don't know it, or all we have left is washed platelets. when we have been faced with recurrent febrile, or allergic reactions, then we have tried to do everything, including plasma reduction, or we have used pre-medication, uh, that will prevent the allergic reactions and febrile illness, like acetaminophen has been used, Benadryl has been used, yet we keep getting recurrent severe febrile or allergic reactions. With the transfusion of platelets, then we go for a washed platelet. Also, in fetal neonatal alloimmune thrombocytopenia, if the platelets will be required from the mother, then we have to wash it. In human platelet antigen, but you can use allogenic human platelet antigen matched platelet donors. Washed platelets must be administered within 4 hours of starting the wash. Then the washing procedure will take about 2 hours on its own. Then you can use plasma volume reduction. So those are the conditions when we will be fully determined to use only washed platelets. How about platelet concentrate? So here, the plasma reduction of platelets can be used before the transfusion of ABO incompatible platelets in a shortage situation, or to decrease the risk of isoimagglutinin, and to prevent hemolysis in platelet recipients. So, like the name is, platelet concentrate. In this case, plasma has been reduced, okay? Then we are battling with ABO incompatibility, right? But we don't have enough blood to transfuse. So we just remove the plasma, and then the rate at which agglutination will occur as a result of red blood cells will be reduced. So red blood cells hemolysis will likely drop in anyone that receives that. Storage of platelets. The shelf life is 5 days from the time of collection and must be kept at room temperature between 22 degrees Celsius to 24 degrees Celsius. We don't need to put it in the fridge, and we're not going to put it in deep freezer. No. It can lose function at lower temperature. That's why it's going to be left at room temperature. It should be kept in a very clean environment. And why that? It can be contaminated easily, leading to very fatal sepsis. So fatal septic transfusion is likely if we're not careful. Platelets do have antibodies, that is ABO antibodies, but you may worry less because that may not likely lead to a serious reaction or hemolysis. It is better to follow the ABO compatibility or the incompatibility issues as per grouping and cross-matching rules. O platelets should be given to blood group O, and resource-negative platelets should be given to resource-negative recipients. If you have to give resource-positive platelets, then it should be to male and postmenopausal women. In case you give resource-positive platelets to a woman of childbearing age or to a very young woman, like adolescents or even children, females that are resource negative, and you inadvertently transfuse them with platelet that is resource positive, then quickly grab your Rogan or Winro to nullify the alloimmunization. What are the possible indications for platelet transfusion? to prevent bleeding in non-immune thrombocytopenia. I'm going to talk more about this later on, non-immune. Because if it is immune thrombocytopenia, we will not be comfortable to transfuse platelets right now because we will be wasting the money and the time of the patient because the immune condition will keep destroying the platelets. Also, we will need platelets if there's bleeding, platelet dysfunction. In thrombocytopenia, due to bone marrow failure, because we know the bone marrow is not producing platelets already, and then we'll give at less than 10, but never in HIT, that is heparin-induced thrombocytopenia, thrombotic thrombocytopenia, hemolytic Remick syndrome, or immune thrombocytopenic purpura. Well, there's no never in medicine, okay? I will come back to this because there is still the window, or a little opportunity for us to give platelets even under these conditions. But it must be in a severe bleeding situation. Ordinarily, we will not give platelets under these conditions. Still on indications, when it is less than 20 and you're about to have certain procedures like PICC line, or transcendences, paracendences, bone marrow biopsy, or bone marrow aspiration, or endoscopy, you can give platelets. Also in neonates, when it is between 20 and 30 and there's bleeding, or you need to have lumbar puncture done, then you can transfuse with platelets. If it is between 30 and 50, you then give if the neonate is less than 1 kilogram, low no bed weight, or there is intracranial hemorrhage, or there is coagulopathy, or you are faced with sepsis, or there is the plan for invasive procedures. Though it is between 30 to 50, you still transfuse with platelets. Still on indications, less than 30 or about 30, and there's an anticoagulant that cannot be stopped, then you just give 1 dose of platelets. If it is high, like 50 or just close to 50, the individual must have a life-threatening procedure like vascular surgery, cardiothoracic surgery, major surgery that you envisage massive blood loss, then have platelets transfusion. Still on indications, at 80 or close, you can give 1 dose if you are preparing for epidural placement or you are trying to remove one. If it is close to 100 or 100 on the dots, you can give if there's head trauma or there's central nervous system hemorrhage or neuralgia surgery. Also, in congenital platelet dysfunction, though you pick this value, you can still go ahead to transfuse. Other indications will include post-cardiopulmonary bypass or bleeding due to antiplatelet agents. Other indications will include life-threatening bleeding conditions with certain situations that we felt that we should not give platelets, like immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, leukemia, myelodysplasia, aplastic anemia, or solid tumors. In these situations, we must give platelet transfusion if there's life-threatening bleeding. Still on indications, when it's greater than 100, in fact, some centers will say, no more transfusion, now we have enough here, the patient will be able to cope. Well, mostly they are right, there's no need of transfusion if it is greater than 100, But you will need to transfuse if this patient will undergo neurosurgery or ocular surgery. Now, contraindication. The contraindications here is, however, debatable because we'll call it contraindications right now. Under certain situations, we will still transfuse because we don't want the patient dead. So in heparin-induced thrombocytopenia, thrombotic thrombocytopenia, hemolytic uremic syndrome, we think if we transfuse platelets, thrombus formation will be on the rise. So some people will say, don't transfuse. But if there's massive bleeding, you will still transfuse. In immune thrombocytopenic purpura, if you have not taken care of the immune process, it is like you just adding water to the system, right? If you are transfusing with platelets when there's immune condition going on destroying it. But if there's massive bleeding, you will still transfuse. When platelet is greater than 100, normally you say, no, that's fine, the patient will be able to go. Now we'll take the sample later on, some days after. No, if the patient with this level will be undergoing neurosurgery or ocular surgery, we'll still transfuse right now. In intracranial hemorrhage that is not requiring surgery, yes, I agree with it. So someone will ask me, are you contradicting yourself now? You call these contraindications, and then you are telling me that though it could be contraindications, that you may still transfuse. Yes, let me do this in 10 seconds. These are contraindications. However, when there is massive bleeding, you will keep an eye on the patient and you will still take the risk to transfuse, but an eye must be kept on the patient. Other than that, if there's no massive bleeding anywhere, if it's just because we envisage that there may be massive bleeding, we should run away from transfusing anyone with these conditions with platelet. But if they must undergo major surgery that cannot be postponed, that is an emergency surgery, or there's massive bleeding, and they belong to one of these conditions, we will still transfuse with platelets. Oh, I leave this page. Intracranial hemorrhage that is not requiring surgery, there is no reason to transfuse. And there is no bleeding. No. Don't give. Side effects of platelets will include non-hemolytic reactions, transfusion-related acute lung injury, transfusion-associated graft versus host disease, post-transfusion purpura that could be treated with intravenous immunoglobulin, then contact hematologist. Hemolytic reactions, septic reactions. Remember, I've stated that there's likelihood of fatal septic reaction, so don't get it contaminated. Allergic reactions and febrile reactions. Okay, note something here. I said earlier that you are not going to transfuse anyone with all these conditions. No, I mean, we are not going to give platelets to them, right? But you can transfuse, even with this, if you are dealing with massive bleeding. But you can ask the question, Doc, why don't you like transfusing people with heparin-induced thrombocytopenia or hemolytic uremic syndrome or thrombotic thrombocytopenic purpura with platelets? Well, let me just tell you here that if there is massive bleeding, I will transfuse. But the reason why I don't want to transfuse is that all those conditions will form thrombus. Okay? And giving platelets will increase the chances of thrombus formation. Remember, platelets aggregation, right? So that's why I won't give it. And then in immune thrombocytopenic purpura, I will not transfuse unless there's massive bleeding. Why that? I just don't want to transfuse unless it is a serious bleeding, because the immune process responsible for immune thrombocytopenic purpura is not yet handled. Until that is handled, if I transfuse, that immune process will destroy the same platelets, those new platelets that I'll be sending into that same system. So I'm just wasting the money of the patient. In countries where they pay, even when government is paying, government is losing money. So you handle the immune process first here in immune thrombocytopenic purpura before you transfuse. And here, because you are afraid that thrombus will be formed, you don't want to give it. However, in these two separate conditions, against thrombus and against immune conditions, when you are not comfortable giving your platelets, if there's massive bleeding that may lead to death, giving platelets will likely still keep the patient with us than folding our arms. Delivery of platelets. There will be specific blood giving set for platelets alone. Only compatible with normal setting. So don't give it with any medication or any other fluid through the same line. Remember, there must be vital signs before transfusion, vital signs during transfusion, vital signs after transfusion. Platelets may be transfused with HIV, hepatitis B, Creutzfeldt-Jakob disease. This is not how many people will have vetted. Many people will write CJD. West Nile virus, malaria, endemic zone, Chagas disease, parvovirus B19, Lyme disease, and babesiosis. Platelets can induce HLA antibodies, so give HLA match in those with persistent problems with random platelets because of the already induced antibodies from the previous transfusion. Okay, if they are both, meaning if you are running into antibodies already developed from previous transfusions, and then you are giving platelets, but the platelet count is not improving, then look for irradiated platelets to prevent transfusion-associated graft versus host disease. Or you give apheresis with platelet-specific antibodies negative. Because when we give platelets with antibodies to platelets, then we keep transfusing so many units of platelets, and then complete blood count will still be showing that the value of platelets is not moving up at all. In fact, can be going down. Yeah, can be going down. So when you are transfusing, your platelets and you are not getting any positive results, either the bleeding pattern is not changing or it's getting worse, or you see that the platelet count is not even going up, it's actually going down, then pause. There must be, autoimmune process going on somewhere, antibodies already acting against what you are giving. So look for the antibodies to platelets or quickly grab irradiated platelets. That will help. Specific human platelet antigen can be used for babies with neonatal alloimmune thrombocytopenia. Note also that you can determine the level of the iron. Remember, iron deficiency worsening platelet dysfunction. So we must take care of iron if we want to succeed in dealing with platelet dysfunction. We have to stop all antiplatelets and give tranexamic acid. We can give as high as 2 grams if there's severe bleeding or the tendency to. To determine the level of iron here, you can do complete blood count and have NCV, total iron binding capacity, and of course determine the stored iron with ferritin, and of course iron level in the blood. Also know that hematocrit should be greater than 30% or hemoglobin of at least 9 grams per dl. We can give desmopressin at this strength if we're dealing with von Willebrand disease type 1 or mild disease of von Willebrand. Hemophilia A, if that's our problem, we can make use of desmopressin. That is factor 8 deficiency, if it is mild, okay? Congenital platelet dysfunction and uremia with renal failure. If platelets is less than 10, we can use platelets prophylactically if we're dealing with hypoproliferative thrombocytopenia or thrombocytopenia with active bleeding treatment or with platelet dysfunction with active bleeding treatment. Platelet is given as 1 dose, which is equal to 1 Buffy-Cope pool, but 1 full dose should raise the value by 30 to 45,000 or 30 to 45 times 10 raised by 9 per liter. 1 hour later, please check your complete blood count. 1 Buffy-Cope pool is a pool of 4 donor units in the plasma of one of the donors, or 1 apheresis is from 1 donor, and it's going to be a single donor unit. If a woman of childbearing age receives results positive platelets, then we must give Rogan or Winrow for alloimmunization prevention at 120 micrograms. If you want to know more about pregnancy and results, please kindly click on this video for further explanation about this, because you will understand later why we take plasma from women and we take plasma from men. All those could be found if you click on this very long presentation on blood product transfusion A to Z. If you click this very link. Finally, the half-life. When you transfuse platelets, the half-life is just 2 to 3 days. So, if you are using platelets prophylactically, then you have to redose in 3 to 4 days. With that, I've come to the end of this short presentation. Someone would say, is that really short? Well, it is, because if you click on this very link, it will take you to A to Z when it comes to blood product transfusion. But that will take about 2 hours, 55 minutes. Thanks for listening. Please remember to share this on your platform. I appreciate it.